to present on understanding prescribers' medication-assisted treatment concerns.
So there are only 3 medications that are currently popular for the treatment of persons with a substance use disorder. In compliance with the CME requirements, I have no disclosures, or actually I did have one disclosure because money was hard to come by as I was in training. So this was a source of most of my income back then. Worked. So in this population that we're looking at, we have already heard that they are particularly vulnerable, and in particular, recently, the standard of care has changed to the use of medication for treatment of this disorder. No longer do we use assisted treatment because, as was pointed out before by Mr. Kent, you do not need to maintain a patient in psychotherapy in order to treat their addiction with a medication, which was an old paradigm. This is a slide that shows you the overdose death rates in the United States. Most recent, this came out in 2019. The data is from 2017. It takes the computers a little while to calculate data as it comes in. As you can see, the opiate overdose deaths has gone sky high. And in Suffolk County, we're actually doing worse than we are in the rest of the state of New York, whereas Nassau County, for those of you from Nassau, is actually doing okay, and they have a reduced rate. I think it's in part because of all the work that's being done by all of you folks here, and some of the work, that has been documented by Sandy at the Northwell system also. So we have 3 types of medications. The physicians are probably aware of them. Most of the clinicians are aware of them. There are only 3 types. There's an agonist, which means that it has the exact same effect as a narcotic, and that would be methadone. It's been around since the 1960s. It's strictly controlled by the federal government, which produces a little bit of the problem in its use. We have an agonist antagonist, which is buprenorphine. You probably know it better yet as Suboxone, because they added Naltrexone to the drug in order to help prevent diversion, which it doesn't do. And at the same time, we have an agonist now, which is used not just for opiate use disorder, but is also used for alcohol use disorder, and some patients do very well on that. The duration of action of these opiates becomes important, particularly to those of you who work in any emergency setting. And the reason for that is that you frequently see a patient come in with an overdose who has been recovered by emergency personnel, whether it be police or EMS, and the patient may at that time be in withdrawal. But if you wait for an hour and a half, which is about the half-life of naloxone, the patient may go back into withdrawal, may go back into the overdose state. So the axiom that's being used at many hospital EDs, I don't know whether it's being used at all of them, so I can't comment on it, is that they wait 2 half-lives, or about 3 hours, before they say the patient is in a chronic withdrawal state, or at least has been stabilized and is not going to go back into that overdose state. Methadone, on the other hand, works for about 24 hours, and buprenorphine may work up to 36 hours. That gives both drugs a little bit of an advantage when they're used for treatment. So we'll discuss the methadone first, and I know I'm running through these things, but I want to get us back onto schedule here, so I'll answer questions at the end. So the problem with methadone is that while it's been around for actually, this slide is old. It's been around for over 60, almost 60 years. Mary Jane Creek at the Rockefeller University and her colleagues actually demonstrated in an elegant study that it could be used to decrease the craving and therefore treat opiate addiction. The U.S. government said, that's terrific, we'll take over from here, and implemented all sorts of rules and regulations and particular sites for this to be obtained. And the regulations are so stringent and so difficult that there are very few private physicians in the country who actually have a license to use methadone for treatment. It does work, however, and we've got 60 years of experience with this drug, and it is very, very effective for patients who remain on it. The induction is kind of easy because if the patient is on narcotics, you don't have to stop the narcotics because you're giving them a narcotic. So that's quite different from the other two medications. But there is a high risk of death in the initial induction for a number of different reasons. Number one, I think, is the fact that you can't start the patient on more than 30 to 40 milligrams a day because of other concerns. And at that rate, at that dosage, you do not suppress the desire to use opiates. And so in that first 2 to 4 weeks, as you're building the dose, patients may experience overdose issues, even using their normal dose of opiate. It is, however, efficacious, and the Cochrane review done in 2009 documented that. However, it is dangerous when it's used with other medications. It is highly regulated, and in upstate New York, for example, to get to a methadone clinic, it could take you a drive of about 60 miles. That's if you're lucky. So it's 60 miles there and 60 miles back. And for the first initial treatment and induction, that can change your life. That's an understatement, and particularly if it's snowing. So that becomes a major issue. Of course, there's also the government interference with what these methadone centers are allowed to do. And of course, as you're probably aware, and we just discussed before, there is a significant stigma associated with those people who are on methadone. And they're certainly not allowed to be in a safety-sensitive job because it is a narcotic, and so it's not permitted. Nevertheless, if you look at the data on mortality, there is a significant reduction in the expected mortality, although buprenorphine gives you the same expected reduction. As I said before, the mortality risk is greatest in the first 4 weeks, but it's also great at the end of treatment. So for those patients who feel they no longer need methadone or are leaving treatment, there is a risk that they will relapse. As a result, there's an increased risk of mortality. This is just a slide, and these slides are available to you after this talk. This is just a slide that shows you the mortality risk during and after methadone treatment. This slide just tells you what the variables are. It can only be released from a methadone treatment center unless, of course, the patient's in a hospital and has a history of being on methadone, then the hospital is allowed to continue the methadone. It is still permitted to be used in a hospital for pain relief. We counsel against using that in patients who are on it at the same time for a treatment of their substance use disorder. And there are times when methadone may be used in a private setting, again, for pain relief, but not for treatment of overdose, not for treatment of chemical dependency. So the buprenorphine efficacy, as I said, has been shown to be pretty good. It's flexible. You can use high doses. In fact, we anticipate that high doses will be used because in lower doses it may not suppress the craving. And that's been a problem in some clinics because the director of the clinic actually has authority as to how far they want to go. We've seen patients up over 200 milligrams in order to suppress their craving, and it works and it's safe. It has an affinity for the mu receptor as does any other opiate, but it doesn't have the same affinity as buprenorphine. Buprenorphine has a very high affinity for the mu receptor, but it has a lower ability to stimulate that receptor, so that as a result of that, the levels of dopamine released by that receptor are lower than the levels that are obtained with a pure opiate. That distance in the area under the curve between buprenorphine and opiates is the reason why buprenorphine given immediately on top of opiate use may produce a withdrawal syndrome, because it has a ceiling effect, which is one of the reasons we can use it, but unfortunately one of the reasons it can produce a withdrawal effect. which can, by the way, be treated. So I don't want anybody to panic about using buprenorphine and finding that they threw their patient into withdrawal, because we can use comfort medications. We can actually even use buprenorphine to treat that withdrawal. So it's a problem. We try not to get into that problem, but it's not an insurmountable problem. The fact that it disassociates so slowly from the mu receptor is fascinating, because you can treat patients with buprenorphine by dosing them only 3 times a week. This is with the oral medication. As you probably all are aware, we now have parenteral medication. We have buprenorphine rods that can be implanted for 6 months, and we have Sublocade, pardon me for using the non-generic term, but we can give a subcutaneous dose of buprenorphine, which is released over a period of a month. So that works out pretty well. The induction period is variable. There are people who will induct the patient at home. It's safe to do that. There are some caveats associated with that. You can induct the patient in your office. Again, that's safe to do. It's easy to do, and we generally advise that you don't use more than 12 milligrams on the first day. However, on institutionalized patients like out at Seafield, it's efficacious for us to induce them with 16 milligrams the first day. We usually just break it into 8 and 8, and they do quite well. Buprenorphine is a very safe drug, even when people try to overdose. It has very little effect after a high enough dose on the medulla, the breathing centers, and so as a result, we do not see buprenorphine overdoses alone. That's almost a reportable event. However, if they use buprenorphine with other agents, all bets are off. Yes?
Okay, so I just did my waiver training on this. Why does the federal government control this medication so tightly, given it is safer than any of the other medications? It's not even a class 2, it's a class 3. So what's give? Do you have any idea? Can you explain that? Because I was completely confused after doing the training, not knowing, and I'm like, well, this is so safe. What's the problem? Why can't I
Okay.
give it to 30 people my first year?
So the question has been, if the medication is so safe, why does the federal government control it so strictly? And the answer is that the American Society of Addiction Medicine and 22 other organizations from around the country are trying to get the FDA to change their feelings about this. There is absolutely no medical, physiologic, or pharmacologic reason for them to be controlling it this way.
Okay, thanks. That's what I thought.
I'm glad you brought up the point.
Yeah, it's bizarre.
Okay. So these patients are stabilized relatively easily. We did make a mistake early on thinking that the principle in medicine is use the lowest dose effective to affect your treatment goal. And unfortunately, we were using too little buprenorphine in many patients, and they still had the craving. And once they had the craving, they went out to get additional medication, usually an opiate, or they sold their medication because it was not efficacious, and they continued to use opiates. In actual fact, the data shows that diversion of buprenorphine is highest in those areas that are underserved by addiction professionals or physicians willing to write for buprenorphine. So it's contrary to what one would have expected. As I said, the addition of naloxone did not really deter people from injecting it, unless they were on methadone, in which case it could cause a withdrawal. But otherwise, they did get high, but they couldn't continue to get high because it has a ceiling effect. And so it's really not a major issue. It may just be an introductory issue for people who were looking to get high on something, no matter what it was. Okay? Now we're finding out that we need to use higher doses of buprenorphine in order to suppress the craving, the same thing we saw with the use of methadone. Buprenorphine treatment can go on forever. Personally, I have a patient, an attorney, who's been on it now 8 years. I used to say 7 years, now it's 8 years, and has had no relapse to opiates. Of course, that says nothing about his use of benzodiazepines and cocaine, but it's another issue. So And I'm glad I brought that up because I wanted to bring up something about buprenorphine. There is a concern on the part of physicians about prescribing buprenorphine in our patients who are polysubstance users. The majority of our patients are polysubstance users, and so far the literature has not shown that there is an increased risk in patients who are using both cocaine, maybe benzodiazepines, and the only problem I would be concerned about is, are they continuing to use opiates? The most recent hand-down from OASAS was on a harm limitation basis, and they said that if the patient is using less opiate while they're on buprenorphine, you're still ahead of the game. So it's not a reason to stop them. It may be a reason to stop and talk to them and maybe get a little bit more into their disease than what you've done already. Oops, that was not the right button to push. So the buprenorphine risk after treatment, as you see, goes down also in terms of mortality. The systems variables with buprenorphine are, interestingly enough, number one, they found that physicians don't believe in agonist treatment. I think I discussed that this morning for those of you who were here this morning. So that was number one. Number two, they don't have the time to either add an additional patient to their buprenorphine practice, or they don't have time to add an additional patient to their practice period. Number three, they don't feel they're being reimbursed adequately. Number four, they don't feel competent to monitor the use competently. And number five, and maybe most significantly, they're concerned about observations by, in New York State, the Bureau of Narcotic Enforcement, the B&E, and at the federal level, the DEA. And they have been active in making certain that buprenorphine providers are doing it the right way. So there's a little bit of reasoning behind their paranoia. I think that's about it. For when you look at the figures on methadone versus buprenorphine, there's actually no difference. So retention remains about the same, and in both, and the experience so far has been very, very positive in terms of that kind of treatment. So the next thing is we have one more medication. Medication for opiate use disorder, the antagonist, is Naltrexone, a long-acting form of naloxone. Works the same way except that it's long-acting. The problem with it is that when you looked at studies about patients starting on this medication, there was a barrier to them starting because you needed to be off the medication about 7 days to 14 days if you read the manufacturer's product literature, but that was written by the manufacturer's attorneys, and so it's not really the risk that you would think. Nevertheless, in a head-to-head study, they found that about 25% of patients who were assigned to the Naltrexone group did not start the Naltrexone because they were busy using opiates, and the study would not permit them to go on it. Nevertheless, we've found that about 3 to 4 days, depending upon the opiate being used, was about all that was necessary. And when you have a question about it, what we would do is give them a naloxone challenge. You just put a little naloxone into their nose as if you were saving them from an overdose, and if in an hour and a half they did not go into withdrawal, it's safe to give them the naltrexone injection. Okay, so it's a blocking agent. Most of our patients, if not all of them, are supposed to wear either a necklace or a bracelet in case they've experienced some sort of trauma. The attending physician and or anesthesiologist would know that they're relatively resistant to narcotic pain relief. As you see, that slide said 4 to 7 days off, not 7 to 14 days. Its advantage is that, number one, unlike the other medications, this is somewhat effective for some patients who have an alcohol use disorder. Not all patients. We're still trying to figure out who and why certain patients are responding well to it. It does reduce the risk of an accidental overdose with this caveat. If you look again at the initial dosing and then the area under the curve as you go out over the 30-day period of time, you'll find that in the 2.5 weeks to 4 weeks, the area under the curve is very, very narrow, and that's the time when patients do overdose because they take a super shot of their medication, or they can take a standard dose, but they're no longer tolerant of it, and they end up overdosed. Okay? So to the extent that that happens, it's probably more efficacious in really serious disease to use this drug every 3 weeks. And I've recently found out that there are patients who are on it every 3 weeks, approved by their insurance company, but I'm sure you're going to have to get a special dispensation to do that. The nice thing is that when you're on naltrexone, you can perform a safety-sensitive job because it's not a narcotic. So again, if you look at retention data, at the end of a year, almost nobody's on naltrexone, but that doesn't mean that that they've all relapsed. That just means that they're trying to get this big shot into their backside. It's about 5 cc's of a viscous material, and there are some problems, especially if the administration is done into the fat and not into the muscle, and that apparently does happen. And they can get a sterile abscess. It's really kind of painful. It's not fun. It's not fun for the prescriber either. Having said that, the days of drug-free time are equivalent to the buprenorphine treatment. So on a head-to-head, people do pretty well. This just shows you that area under the curve as it diminishes over time. As I said, again, these are, you don't have to draw a picture, it'll be on the presentation. And when you compare them, they look to be pretty good once you stabilize the patient. This slide actually, again, I'm just going to briefly refer to it because it shows you methadone, buprenorphine, and naltrexone extended release. And it shows you, you know, where each thing works, what each patient's characteristics are, and it's just really kind of nice. The nice thing is that you don't need a double lockbox if you're going to store naltrexone. You just need a nice refrigerator. Whereas with the other medications, if you have methadone in the hospital, you need a double lockbox. If you have buprenorphine in your clinic or your office, you need a double lockbox. And of course, when the regulatory agencies come in, they're looking for that double lockbox, okay? So the summary, induction, retention, most challenging for naltrexone. Methadone patients seem slightly better than buprenorphine. That's an old slide, it's no longer true. They're about the same. ACOG has cleared the use of buprenorphine as now equivalent to methadone in pregnant women. Before it was a second-line drug. They said, well, stick with methadone because we know more about it. And they recently, last year, said, nope, you can use buprenorphine. We do not use a naloxone added agent. We don't use, in other words, Suboxone in pregnant women because the fetus is extremely sensitive to withdrawal. And the last thing in the world you want is a fetus to go through withdrawal because they don't do well. Okay. I think that's all we need to know. We just know that it works. Okay? Questions? Oh, wonderful.